So what we're going to be looking at here is immediate care and tissue healing. So we're going to look at some of the time frames in as far as immediate care of injuries. We will not be looking at the information on ice that is covered in the chapter in the text. We're not going to be going through that. We're strictly just going to be looking at the immediate care issues, and then we're going to get into the tissue healing portion, or the other phases of the healing process. We spent a good amount of time talking about the acute inflammatory phase. We're going to be talking about the repair phase along with the remodeling phase within this section. So this is a scenario that I'm actually going to have you address in class as a group. We have a women's basketball player with a grade 2 ankle sprain, 2 days out. What problems would this individual have? What would be happening up to that point? So in other words, what would be some of the physiological things that would be happening because of the fact that, where the injury is at within the days afterwards? What do we need to do, and when should exercises start? So think about some of the information that's in this chapter and also in the previous chapter that we've talked about with the inflammatory phase. So when we broke down injury based upon acute and chronic injuries. And what we're addressing here right now is looking at acute injuries. Even with acute injuries, the immediate care is not the same necessarily for all acute injuries early on in the process, because of the fact you have varying degrees of injury with acute injury situations. There may be some circumstances where the care isn't always going to be the same. So you basically will have 3 main stages. You have acute care, subacute care, and post-acute care. Now, within that acute care, there could also be potentially some other sub-areas of care where you would have to be obviously dealing with things much differently. And they're broken down on here. So with under the acute care, which is the 0 to 4 day mark, you have emergency care, immediate care, and transition care. Now, obviously, this varies depending upon the severity of injury. So with, for instance, obviously a grade 1 ankle sprain, we know we're not calling an ambulance for that. But if it were a situation, let's say someone dislocated their ankle. Okay, so obviously the immediate care of somebody who dislocates their ankle is going to be very different from somebody who has a grade 1 ankle sprain, even though they're both acute situations. So the way this kind of breaks down is it looks at your emergency, immediate, and transition care if it is indeed applicable to the situation. And then obviously beyond that, we have your subacute care, which is about 4 to 14 days post-injury, and your post-acute care, typically greater than 14 days. Again, note your injury severity as that applies. So these are the problems within the acute phase that we're looking to minimize, okay, or looking to decrease because of how it will impact the overall healing process. So up here we have our 5 main problems: pain, swelling, muscle spasm, neural inhibition, and secondary injury. So obviously we know, again, pain is going to be caused by the initial trauma to the tissue, the irritation of the nerve endings, the damage to nerve endings, the chemical mediators that get released. The swelling is going to occur, again, because of some of the chemicals that get released, the free proteins in the area, the tissue debris that's going to draw fluid into the area. Muscle spasm, which will also contribute to pain, is going to occur in order to protect the area. Neural inhibition is another protective mechanism. So the neural inhibition is going to be, again, the muscles around the region will want to shut down because in an attempt to, again, not use the injured limb. And then our secondary injury, which we talked about at length in the previous discussion, is something that comes about. So again, this is when the tissue cells that were not involved in the main injury start to get damaged due to the processes that we've talked about. Okay, the reduction in circulation, the decreased oxygen to the area, again, not being able to meet the metabolic needs of those cells. Again, do we want to reduce or eliminate inflammation? And the answer to that question should really be no. We don't really want to do that, because if you reduce inflammation, you are going to decrease the efficiency at which the tissue heals. What we want to do is try to control it, if you will, and minimize these signs and symptoms, because these will be things that, even though the inflammatory process is good as because it allows healing, it's also not going to allow the person to heal or rehabilitate as quickly, because they'll be limited by these different problems. So when we talk about immediate care of injuries, again, we talk about RICEs, so rest, ice, compression, elevation, and stabilization. We will get into in class the evidence as far as how effective RICEs is with certain types of injuries, but for now we'll just kind of go with the conventional why, what it is, why it gets used. So with RICEs, again, you initially rest, again, not too much. The reason being is you don't want to have delayed healing. Okay, if you rest too much or immobilize the area too much, you're going to get delayed healing, you're going to get adhesions, you're going to get atrophy, there's going to be loss of conditioning, loss of confidence. So anytime you can get a body part moving, get it moving. Again, still has to be within healing constraints, but if you can move a body part, move it. If you can't move a body part, move an associated body part. We're going to apply ice to limit secondary injury and also decrease neural inhibition. The application of ice will do that. Again, the question I pose is, does ice eliminate swelling? Again, ice does not, listen to me very carefully with this, ice does not eliminate swelling that has already formed. Okay? So that's an important thing to know. It can limit the amount of swelling that does form, but once it's there, it can't get rid of it. Okay? Compression is going to be used to control edema. Okay, so it'll control the edema formation. It'll also enhance cooling if you apply compression with the ice together. Elevation is going to decrease capillary hydrostatic pressure, which will further reduce swelling in the region. Remember, we talked about oncotic and hydrostatic pressure. So the oncotic pressure, again, is the pulling pressure caused by the free proteins and cellular debris that pulls fluid into the area. The hydrostatic pressure comes from pressure being above the region. So if the area gets elevated, it reduces the pressure and will allow for some of that swelling to come down. Stabilize as necessary. That'll just help controlling the neural inhibition and also decreasing the pain spasm pain cycle. So that's kind of the goal of each one of these things in as far as what it is you would be doing. So now we're going to look at some concepts in as far as the actual repair of tissue. And again, remember, some of this is going to be started even during the inflammation response. Okay, remember those three big phases: the inflammatory response, the repair response, and the remodeling response all kind of run into each other. The first thing we're going to look at is the difference between reconstitution and replacement. So reconstitution occurs in cells with a normally high rate of turnover. So what this basically means is when the cells are damaged, they get replaced by identical cells. With replacement, they get replaced with simpler cells. And this is what we're typically going to see with connective tissue. Connective tissue isn't going to heal with the same type of tissue with there. It's going to heal with scar tissue. So knowing and understanding that, we have two different types of healing intention. We have healing by first intention, we have healing by second intention. So healing by first intention is what we typically see with very small incisions, with surgical scars, very small, neat cuts in the tissue, if you will, very small scar, very unnoticeable. Second intention is when you have a wound with a much bigger gap and that will be repaired with a lot of scar tissue. So there will obviously be a lot more needed in as far as, particularly when you're talking, damage to, say, like a ligament, remodeling and everything needing to be done in order to kind of fill in for that damaged tissue. So getting into the repair portion of this. So the first part of the healing repair phase. So again, this is basically coming right after or within, or not even necessarily right after, but within the inflammatory phase. And this phase in particular, this initial hemostasis and inflammation. So these events, even though they're associated with the healing repair phase, very much closely are associated with what is going on in the inflammation phase. And as we're talking about some of this, it should sound very similar. So hemostasis and inflammation, you have the cellular and vascular phase of healing. And what we're looking to do here, and again, we're looking to eliminate extra protein and dead cells just to make sure we don't have any excessive scar formation. We're looking to use the cellular events of healings very similar to the leukocyte formation and the macrophagy response of the inflammatory phase is what's going to be going on during the cellular and vascular phase. So those same basic white blood cell activities that you had are going to be kind of going along with this phase as well. You're going to get an initial clot formation. And again, this is going to be that this coincides with the hemostasis, so it's going to limit the amount of bleeding that occurs, both from the damaged blood vessels and also from the damaged tissue in the region. And then you're going to, we talked about the white blood cell activity, primarily a lot of macrophages in the area, which are going to again be eliminating cellular debris, and also again that's going to contribute to that limitation in the scar tissue that I was discussing earlier. And the lymphatics are going to be operating in order to drain some of the fluid from the region. Okay, and as we recall from 310, in order to get our lymphatics to work, the lymphatics are a passive vessel, so they really need muscle contraction in order to really utilize that in order to promote drainage from the region. The epithelialization, how much this plays a role is really going to depend upon the type of wound. So epithelial tissue is a membranous tissue. Usually with smaller wounds, you're going to have more epithelialization of tissue. Your book gives the examples of blisters or very superficial abrasions. Really all that healing is epithelial tissue. With bigger wounds or damage to tissue, the epithelial tissue is just going to be a covering that just kind of helps protect the tissue that was initially damaged. So greater epithelialization with smaller wounds. Obviously with bigger wounds it's still going to be there, it's just not going to have the same impact. The next portion of the healing phases we'll look at is proliferation, and there's three really big events that go on with the proliferation phase. The first part of this is angiogenesis. So angiogenesis is the formation of blood vessels, more particularly in this instance capillaries in the region. So this is going to be what provides the blood flow to the tissue that's going to be coming in to help with the healing of the damaged tissue. Usually this takes about 4 to 6 days to take place, and as you can see, what goes on here is you get little buds forming all the way to arches, and then you get what's basically called an arcade. So these capillaries form. Now these are only temporary capillaries. They don't remain there once you get into the remodeling phase. These capillary arcades that form once all the arches are kind of built. These collapse are no longer there. They're basically there to improve blood flow into the area. So the next portion of the healing phase is what's known as collagenization. So this is when your collagen is going to start to get laid down, and this is going to be stimulated by fibroblast activity. Again, what's needed to optimize, what's going to be needed to optimize this is oxygen. So again, making sure that, obviously we're going to have the angiogenesis occurring, but making sure that the swelling that's there is getting eliminated, to make sure that blood flow to the area can be enhanced, make sure the body part, if it can be moved, is moving. That's going to further enhance that. Most of the collagen will be laid down within 15 to 20 days typically, and it's going to be what's known as a type 3 collagen. So that type 3 collagen is basically just going to get laid down in a very random fashion. So all this early initial collagen, as you can see in the picture below, they're showing you a picture of type 3 collagen. It doesn't line up the way the normal tissue fibers would line up. It just kind of gets thrown in randomly just to kind of fill a gap. So again, it will serve some purpose, but it is going to be very weak. It's not going to be anywhere near as strong as the initial collagen that was there. Your next phase, you look at wound contraction, so pulling the edges of the damaged tissue together is going to happen then as well, and this is going to occur with what's known as myofibroblast. Typically in a smaller wound, you will see many more myofibroblasts, and you'll also typically see a smaller scar with this. So again, 15 to 20 days, most of your collagen, and again, it will be of the type 3 type of collagen that will be very weak and in a very random, unorganized fashion. Now the last part we're going to be looking at with the healing phase is the remodeling, and remodeling is the third and kind of final phase. So you have your acute inflammatory, your repair, and your remodeling phase. So remodeling phase, also known as the contract and restructure phase. So what you're going to get here is a decrease in the amount of capillaries and the myofibrils, and the goal of this phase is to allow the tissue to remodel along the lines of stress. So if you remember in that previous picture, you kind of had a very random laying down of tissue. It was kind of all over the place. Now you kind of see all the tissue fibers are all in good alignment, okay? And this is the goal of the remodeling phase. The other thing you will see is a decrease in the amount of type 3 collagen and an increase in the amount of type 1. Type 1 is a much stronger collagen that will be coming into this area. And really, this is what you want. You want these fibers to reorganize. You want them to align along the lines of stress. And this is where exercise becomes very, very important. And again, it shouldn't be where exercise starts in the remodeling phase. But certainly this is where you want to really have a lot of what's being done very active on the part of the patient. So again, you'll get that collapsing of the capillary arcade. You won't need as much in the way of extra blood flow to the area. Obviously, the normal blood flow to the region will suffice at this point, and you will again have an increase in that type 1 or that stronger collagen. So now we'll go through and look at what happens with tissue. So let's pretend that we have body tissue and we have damage to the area. So this little picture here represents damage to some type of tissue. So let's look at it as that it's a torn ligament. So remember, early on with damage to any tissue, you will get some bleeding. Okay, now again, the bleeding is going to stop relatively quick because we're going to have the clotting process. So you will initially have some early hemorrhage. So that then leads us into the formation of edema. Okay, and we know how that edema is going to form based upon what we discussed in the earlier discussion on the inflammatory response. So remember, with damaged tissue, it's going to signal chemical messengers out. Those chemical messengers are going to allow increased blood vessel permeability. That's going to allow some free proteins to leak out, and that's also going to draw tissue out. Remember, the tissue oncotic pressure is responsible for the formation of edema in the area. As far as effusion is concerned, effusion is when you get swelling inside of a joint. We refer to that as effusion. So that will lead us into clot formation. And the clot formation will actually be what in the actual damaged tissue itself what is going to form the basis of what's going to be the actual scar tissue that forms. And that will lead to the formation of more fibrin. And that would bring in even more fibrin. So again, we're laying down fibrin to, remember that's the protein fibers when you have your clot. So remember, clots are made up of fibrin and platelets. And then once you have enough laid down, you then have a full-blown clot. Okay, so again, this will be the kind of base for where the scar tissue then is going to be formed. So from the standpoint of the repair process, we know that we're then going to be laying down scar tissue. That scar tissue is going to be collagen formation, and that's going to be formed by these cells known as fibroblasts, which we've talked about in 310 as well. So these fibroblasts are going to be the cells responsible for the formation of collagen in the region. So then around approximately day 5, you'll start to get the actual formation of collagen tissue. So that little purple lines in there represents the actual formation or the beginning of the formation of the collagen. And again, usually around 5 days to start. Remember we said 15 to 20 days you will have most of your collagen, your initial collagen will be in there laid down. Again, this will be your type 3 collagen. Again, the random weak type collagen that will get laid down. So again, 15 to 20 days, approximately 3 weeks. All of your random scar tissue will be kind of laid down and filling in that gap. And then that will take you into the remodeling phase. So as the area gets utilized, the collagen will line up along the lines of the tissue stress. So you can see here what would be represented as a much stronger, more organized type of collagen. This will be your type 1 collagen as it gets laid down during the remodeling phase. Again, some of your other things that will happen and occur during this process in the remodeling phase, again, the capillary arcade that was formed will collapse because it will not be needed anymore. And again, that tissue in the region will gradually get stronger and stronger. So when we look at the proliferation of new tissue, and another kind of phrase they used, they sometimes call the repair stage of healing the proliferation stage, is the formation of granulation tissue. And you see this more obvious in a lot of superficial wounds, but the same kind of concept is going to happen in damage to connective tissue that you see with musculoskeletal injuries. So the granulation tissue is basically the combination of collagen and ground substance. Now we talked about collagen already multiple times, including in the last class. It's basically the protein component of your soft tissue. What ground substance is almost like the best comparison would be it's almost like a gel. And what it does is it prevents friction between the collagen fibers. So, and you have that also in healthy tissue as well. Granulation tissue is very vascular, and it's also very good at resisting infection, which obviously for musculoskeletal injury purposes isn't really all too relevant. But when you're dealing with your superficial wounds, it's obviously very important that you resist infection with that initial tissue. So some different characteristics of scar tissue, and some of this is probably pretty obvious. It's not going to be as vascularized as original tissue. Basically everything, the scar tissue that you get is never going to be as good as the tissue that was there. The idea is that you try to remodel it as close as you can, so to not have any other problems in the future. It's not going to be as flexible, elastic, or strong. Obviously if it's in a If it's in an organ, it could possibly inhibit function. Now, we're not going to be dealing from a rehab perspective with scar tissue in the heart or the bladder, for instance, but obviously there's impact there. It could form adhesions, and when we get into some of the massage and connective tissue work, we'll talk about how we can maybe try to limit some of that. And it could also form contractures. We're going to spend some time in talking about massage, kind of the proposed effects as to how massage works, and kind of breaking up a lot of the contractures that form within the skin and the muscle and the fascia. Remember, all that soft tissue is connected in some way, particularly when you're looking at the impact of the fascial tissue that kind of covers everything. So really important to be able to work on that as quickly as you can to make sure that that scar tissue doesn't bind down and cause any major loss in range of motion. So in kind of looking at healing and repair, there's some modifiers, if you will, or things that will assist in the process of healing. So we have our immediate care, things that we do, and again, we're basically looking to limit a lot of the early events, particularly as it relates to inflammation and a lot of the symptoms and things that occur. So for instance, the hematoma formation. The smaller the hematoma that forms, the faster your repair is going to be. Okay, so that's going to be a huge benefit if you limit that in your immediate care with modalities. The smaller the wound gap, obviously the smaller the wound, the less amount of scar tissue you're going to have, then the easier the healing process will take place, and that scar tissue will have limited impact. As far as exercise is, again, I talked about this earlier, exercise is really going to be the thing that gets people better in the end. A lot of benefits to early exercise. You're going to increase circulation to the area. You're going to increase oxygen delivery. Again, you don't want to be too vigorous, but moderate exercise early on, as long as it's within their ability and it's within the healing constraints, there's going to be more benefits than drawbacks. If they're a little sore after exercise, you apply your modalities post-exercise to limit their pain, limit any type of edema formation. As long as they're not coming back the next day complaining that they were in a lot of pain that night or still in a lot of pain that next day, exercise is fine, given, again, it's within the healing constraints. So lots of benefits as far as that's concerned. Obviously, the application of therapeutic modalities. If you look at Table 7.1 on page 130 in your book, they go over the general roles of the applications of therapeutic modalities in healing. So, modalities, what are some different things they could do? They could stimulate healing. What are modalities that stimulate healing? Ultrasound can do that. Some forms of electrical muscle stimulation can do that, and hot packs can do it. Promoting lymphatic drainage. What are some modalities that can do that? Massage can promote lymphatic drainage. Cryokinetics, the alternating application of ice and exercise, can do that. Intermittent pressure devices, okay, or edema pressure devices could do that. Moderating pain is another thing that can do this, thereby facilitating exercise. Again, cryokinetics could do that. Cryo stretch, or the alternating of cold and stretch, could do that, and obviously some forms of electrical stimulation, more particularly your TENS, your transcutaneous electrical nerve stimulation, can do that as well. And again, all that information can be seen on that table in your textbook. And good nutrition. Good nutrition can go a long way in doing that. You can see a little picture of my daughter from years ago. She has a table full of vegetables and noodles and things like that, which is obviously very healthy and can contribute to healing. Birthday cake, not so much. So again, all of those modifiers will play a role. Just again, important to understand, particularly the physiology with the immediate care, the benefits of early exercise, and what some of the different therapeutic modalities can promote. Now, obviously, a lot of our focus is on, connective tissue injury. When you look at superficial injuries, particularly lacerations, again, the same healing issues are going to be taking place here. The key is with superficial wounds to close them as quickly as you can. You want them to try to heal with primary union. Again, that's going to limit your superficial scar tissue. We can do this a lot of times, early application of steri strips, and if necessary, sutures. And ideally, if you can do that within 4 to 6 hours after the actual injury. I know from my standpoint, I've had a lot of lacerations. I've steri stripped well right away. You know, after an event, got someone to go and get sutures, and a lot of their scar tissue has been very limited. So ideally do that as soon as possible within a 4 to 6 hour time span, and you can certainly limit a lot of the scar tissue. And again, particularly if it's on the face, some people don't enjoy having big scars on their face, so the patient will be pretty happy with you. So this is going to be something that I'm going to have you guys, as some of your in-class activities for the next in-class meeting, I'm going to have you guys talk about. So when you look at your therapeutic modalities, what you have to think about, what is the priority that you're looking to work towards? Again, I'm a firm believer that I think a lot of times too many modalities are applied in just a random purposes and reasons. Have goals. All you got to do, if you just match the modality with your goal, you can't be wrong. You know, so it's just a matter of understanding the physiology as to how they work. So think about some of this. I'm not going to do a discussion post on Blackboard necessarily related to it, but you're going to be talking and doing some of this for the next in-class meeting. And again, this is the scenario, and again, you're going to address this in class. Again, the women's basketball player with the grade 2 ankle sprain. So think of some of the things that we talked about, not only in the previous discussion on the inflammatory phase, but think about what we talked about here and the modifiers. So what are some things? How would that impact your decision-making process? And you don't necessarily have to come up with exercises at this point, but I want you to put some thought into you know, what should be done for this person, at least early on in the process. And our learning outcomes. So again, think about what we talked about. If you're confused at all, again, there's some, particularly early on in the repair phase, there's some crossover with the inflammation phase. So understand how they're related, but at the same time be able to pick apart the physiological processes, because a lot of what we're going to talk about, or I'm going to test you on the first test, is ask you about, like, you know, what cells are present during this event, or what happens during this event in this, you know, part of the process. So make sure you're able to, seeing how they're related, but at the same time being able to pull them apart to understand what's going on in those individual phases. So particularly when you look at, like for instance, the hemostasis and inflammation component of the repair phase. So there's things that tie into, obviously, I mean, just by the name, there are things that tie into the inflammatory stage of the overall healing process. So make sure you can differentiate between those, okay? And again, if you're having trouble or have any questions, by all means, you know, contact me, and I'll be more than happy to differentiate those for you.